Okay, I'm going to see if I can talk even faster than the past two speakers.
That was great.
Let me get going here. Okay, so there is the disclaimer because I've had my hand slapped a few times already. So I manage one of the Healthcare Innovation Awards. It was awarded in 2012, so we just completed our third and final year, although we may have a no-cost extension coming. It was built on the pilots that Arnie Milstein and Alan Glasseroff founded for a couple of our member companies that had successful outcomes. And PBGH's vision in applying for this award was to build an infrastructure clinically and operationally in California so that we could spread the model to the high-risk employees of our members. During our first 3 years, we became well known to the state of California, and we're partnering with them. And right now, we will be providing the training and technical assistance to the clinical sites called CBCMEs, who will be seeing patients during the 8 quarters that the health home goes live. And that's a pretty big deal. It's meeting PBGH's goal, of course, of multi-payerness, and it runs concurrent with a lot of the work that we're doing with our commercial members. So IOCP is a program much like what you've heard about today. It's high touch, it's care coordination, it's the patient as a partner, team-based care using all kinds of care coordinators, licensed and unlicensed, working through transitions of care and facilitating communication across all of the service providers. Our criteria include 2 chronic conditions. We meet behavioral and psychosocial needs. What we see the most of are anxiety and depression. And it's really that band that everybody's talked about where you can actually make an impact. It's not palliative care yet. Their outcomes can be improved through self-education, learning to identify when an exacerbation of illness is about to happen, and through care in outpatient settings. You can see there the conditions that we happen to see the most of. We only have one exclusion, and that is for patients only in hospice, and then our partners can make the determination about the others that they would like to keep in or exclude, usually depending on what the capacity is in their community. So we reached 15,000 patients as of about a couple weeks ago, and that was our target for CMS. We were very enrollment driven. We had 23 participating partners in 5 states, touching about 500 practices. And I'd say 20 of the 23 partners are keeping IOCP. They are sustaining IOCP in their models, and they're doing that by integrating it into their overall population health strategy. We had a lot of variations in how our programs were organized. We had Medicare ACOs, we had Medicare Advantage, we had straight fee-for-service. I can say that the take-up is much greater when you have risk. That's kind of a no-brainer. But we did have some fee-for-service sites that saw this as an opportunity to get a lot of the training that we became well known for and to get on their training wheels and then get off their training wheels to get ready for more risk-based contracts that were coming their way. And then we also had IPAs, medical foundations, we had integrated systems, non-integrated systems. Very hard in an IPA environment, especially the looser the IPA, the more the docs are spread out from the management services organization, the harder it is to bring them in and get them to refer patients. But it does work. Some groups did find a way to do that. And it also goes without saying that when you have integrated providers in hospitals, it's a lot nicer when they're not fighting to keep people in and keep people out at the same time. But that also worked. So I don't want to spend a lot of time on our guardrails. You do have a 3-pager in your briefing book This is what we consider to be essential to our model, and this comes from Alan and Arnie and Pranav Katari, who've all been doing this out in the community. But it is, you can see very much patient to care coordinator, regular communication, not just pushing out appointment reminders. And there's a super visit that takes place at the beginning where we use the assessments for both patient activation, depression, and physical and mental functioning. And the super visit is really important because it's where the relationship starts, and it's not real clinical. It's about the care coordinator getting to see where the patient lives, what the social determinants are, what the home looks like, and that kind of kicks everything off and builds a trusting relationship. So I mentioned that we do process measures, and here we are. We've seen improvements in physical and mental health functioning. We've seen a dramatic improvement in the depression score, and we've seen improvements in PAM. We've also seen some stay the same, a little bit of decrease. As Alan mentioned earlier, when you already have 3s and 4s, it's hard for them to increase. I think some other reasons for seeing same or decrease is that care coordinators don't always do the 6-month follow-up, even though they're supposed to. And if they do it, they don't always record the score. But we did see a correlation between increased PAM scores and graduation among patients. And so now, to get to the big elephant in the room, you're wondering, where are the utilization metrics? When are we going to see that? We don't have them yet. We had a lot of data problems when you have data being submitted from 20 different sites and the quality is variable, and some of them are missing social security numbers and addresses and all that good stuff. It becomes problematic. So we have some actuaries doing some deep dives right now, looking at differences by risk score, chronic condition, geography, medical group, but we don't have that yet. And I mentioned that 2/3 of our enrolled patients are in Medicare Advantage and 1/3 is in fee-for-service. The tragedy of that is the Mathematica evaluation that's going to be coming out from CMS is only looking at fee-for-service, so 2/3 of our patients will not be included in that measurement. So to the heart of the matter now, and how am I doing on time?
You're doing good.
Okay, good. So we built these programs, and we built them from scratch. And we started with what I call the A list of medical groups in California, those that already had a track record, they do well with innovation, they had infrastructure in place, they had leadership that really supported this. And we got them going within 8 or 10 months. And then later on, when we had expertise, we were able to take the ones on training wheels that I mentioned earlier and get them up and going. So there are a lot of characteristics that anybody who's run a program like this will see things that are common about what you need to make them successful. Some of these seem very self-evident. We had to allow a lot of adjustment for local environments after the guardrails were met. So for example, in some areas there's no capacity. Santa Cruz County had one psychiatrist and he retired. And they can't recruit another psychiatrist in or social workers because even though everybody wants to live there, nobody can afford to live there. We have, there are the physicians who don't want change no matter what. There are nurses who can't adjust to the new way of working with patients. They're used to working at bedside in hospitals, so that's a hard one. And we saw more churn than we expected to. The closer the physician, the practicing physician is to supporting the patient into the program, the better the engagement is. We have almost 100% engagement in some of our groups where the patients are entering through a single portal, they're being triaged into the right care coordination program, and it was their doctor who got them there. We see 33% on the other end where patients are just receiving a letter. And then again, some of these are no-brainers, but they're worth saying because we saw senior leadership come to meetings, we saw a lot of lip service, and then they completely disappeared. There was really poor communication within the medical groups where What we were saying to the leadership and to the managers was not getting passed down to the care coordinators, so they didn't know what they were supposed to be doing. You have to identify the appropriate patients. We left that at the local level. Each group used their own predictive risk model. It was supplemented by a physician or clinician of some kind going over the list. And then we allowed physician referral into the program because some patients don't show up on a list, but they really need to be in the program. One of the learnings that had to happen was when a lot of the nurses were doing the chart review to make sure a patient was appropriate, they were pulling in a lot of patients who were more appropriate for palliative care. And then they had trouble disengaging with those patients because they really wanted to help. We used a lot of strong analytics to measure how our programs were doing. We had some pretty hefty targets we had to meet for CMS. It was like all metrics all the time. And that really helped us, and we were able to feed that information back to the groups, and then they could make mid-cycle change. And what are the implications of this? Well, I said already a couple times, risk matters. One of the ways programs can sustain is if you create demand for them at the provider's site. And one of the ways to do that is by making providers more accountable for both their utilization decisions and for their own performance. And when you do that, they want to change the way they practice, and they respond, and that creates a demand for new models of care. Global payment is great, and bundled payment is great, moving toward total cost of care. All those are tools. Continuing to refine P4P, all that helps. I've heard talk today about the care coordination codes, and I think we all agree it's a step in the right direction, but it's really not sufficient. We have all the medical neighborhood providers we've been talking about, not just mental health and behavioral health, but we're talking about food banks and transportation services and area agencies on aging. And at some point, they're going to have a volume, and they're going to need to have support in order to keep that going. And then again, our mantra has to be multi-payer. You have to create a solid revenue stream for physicians in order to keep these programs going. And you have to make sure that they're not, let me back up for a minute. We all know that physicians don't make distinctions in how they treat patients based on payer source. So we have to make that easier for them. And we have to create better communication and better efficiencies. And I did it within 1 minute.
Okay, good. All right.